Good morning, afternoon, evening, whenever you're watching this.
Welcome back to the Dr. Joe Show. Welcome back to the Dr. Joe Show. This is healthcare literacy. And today we have with us a special guest from Hospice, which is a hospice agency in the state of Arizona. They have a presence all over the state. I have Carmen with me. Welcome, Carmen.
Thank you.
Thank you very much for being on the show today. This is Dan Sfer, my co-host.
Nice to meet you.
Of Yuma Clinical Trials.
Thank you for coming.
Thank you for having me.
Well, so the main reason I wanted to have you here is I think a lot of patients don't understand what hospice is and when it's needed. Mm-hmm. So let's just start from there. Give me a background on yourself and tell us a little bit about this.
So I've been in hospice for the past 10 years. And my role as a hospice care consultant is meeting patients and families and explaining hospice services, as well as meeting with referral people, which is the doctor, the nurses, case management, and help them identify those patients that are in need of hospice care. So any patient that is declining, that within the last 6 months, they saw a decline, if it's eating less, weight loss, maybe they were walking, now they're not, COPD, a lot of the times is they have a hard time getting oxygen, and we provide that within hospice care. Anybody that is not looking to do any aggressive care, those are the patients that we want to help out. Maybe continuation of going in and out of the hospital, that sometimes the patient doesn't want to go, but maybe the family wants them to go. Well, we can bring all that care at home at the comfort of their home, wherever they call home is. If that's at a house, assisted living.
The hospice at the house.
Yes.
Okay.
So assisted living, group homes, nursing facilities, wherever their home is at.
Mm-hmm. Okay. And the difference between palliative care and hospice care, I think patients have trouble understanding the difference between that. Tell us a little bit about that.
So there's kind of two palliative within palliative care. So there's palliative within hospice, meaning we manage your symptoms for pain management. Palliative care, you can receive aggressive care, and that is not with hospice, meaning there's a nurse practitioner that makes visits at home, and they manage their symptoms, and they still can receive aggressive care, like still receiving chemo, still receiving dialysis, and they can have palliative care within their aggressive care. Mm-hmm. So just depending what palliative they're looking for, right? Do they want to stop treatment, or do they just want to do comfort?
Yeah, I think a challenge of a lot of physicians is not knowing when to ask the patient, do you think you're interested in something like this?
Well, I think, we need to start looking at our patients of other options that sometimes I don't think we give them the option of hospice. We just feel like we need to treat the patient, but there's different scenarios. Maybe it's age, maybe there's complications. So we really should be giving the options from the very beginning. Say, hey, there's option for hospice, or do you still want to receive aggressive care? And a lot of the times is the doctors are not explaining that to patients, that there is an actual option of hospice, and just be comforted at home, wherever their home is, and just be around their loved ones, because a lot of the times is, well, the doctor hasn't mentioned that to me, that I could do hospice. And it's the neighbor and friends that are like, there is other programs that you could be receiving. So a lot of the times as doctors, we let the doctors know, and they're like, but we didn't give the order. Or they're noticing the decline. Maybe, they used to leave their house and now they're not. And so at that time, they can let us know, hey, you know what? Mrs. Joan hasn't came into the office, or she can't make it to the office. A lot of the time they want them to come into the office and they can't. So we can make that visit and put eyes on the patient and say, you know what, Dr. Joe, I think it's time for hospice, or you know what, they can make it to your clinic. So a lot of the times is, a lot of doctors don't make home visits, so they don't know the situation or their household, or maybe they have no family and people are not managing their medications. And so there's just a lot of different scenarios that sometimes we can put eyes on patients and kind of let them know, like, maybe this is the right fit for us, hospice, or maybe it's home health, maybe it's palliative. I mean, we can do referrals to different things if the patient is ready for that.
I think you said the most critical point. The most critical point is home visits. Physicians don't do home visits anymore.
No.
And most physicians have completely forgotten the third pillar of being a physician, which is palliating. Mm-hmm. Because we're supposed to diagnose, we're supposed to treat, manage, cure, if we can, and then palliate. Mm-hmm. But most physicians only do the first two.
And they never goes to the third one.
That's why hospice became its own thing.
Mm-hmm. And with hospice,
home visits. It's all about home visits. Mm-hmm. Oh, that is so interesting.
With hospice, we have our doctors that make home visits, and our nurses that, of course, are communicating to the doctor what they're seeing in their patient. Depending on what's happening is how we do our visits with the doctor that can come in to do symptom manage, or after 90 days, I have to make a visit, right? But a lot of their doctors, primaries or specialists, don't make visits at home. So and so that becomes very complicated for families, because a lot of times they can't wheel him into the car or get him in, or just sitting there in the lobby waiting for hours to be seen, because the doctor doesn't know that this is a patient that has declined or needing more extra support.
Yeah, or you don't have time to think about the patient much or talk to the patient much, maybe, and then you just say, oh, well, they need to go to the ER, or maybe you're booked up and they can't come in, and you say, go to the ER. And maybe if you had a few minutes to see them, then you'd say, maybe waiting 8 hours in the ER and suffering there and possibly, being gone hours later, maybe it's not good to go out in the waiting room. Mm-hmm. So that's all stuff to think about, folks, not to be on the negative side, but people need to consider these things. Culturally, I think people are very afraid of talking about death.
Absolutely.
And
even just advanced directives, right?
Even just advanced directives.
Just having things in place. It's like a conversation. I don't know. In our culture, it's like we don't talk about death because that means you want me to die. And not necessarily is just helping your family make decisions that you made, not that your family has to make. Because a lot of times they have guilt of like, oh my God, I took him off life support. I killed him. When reality is that they were already there. You're just helping them, or different scenarios, right? That sometimes we don't want to talk to our families about, or, funeral arrangements or any of that. People really struggle with that. And I think having those conversations early on, and they say, when do you have an advanced directive conversation? Really, at any time, at any age, any symptoms that are rising, we should be having advanced directive conversations.
Or anytime you have a strong opinion about it. At least jot it down in a journal. That's better than nothing.
Exactly. So then when your family doesn't feel guilty of making whatever decision they need to make for you. Because we don't have to be ill to get, to die. We can have a car accident.
Something could happen, yeah.
And then we don't know what your wishes were.
Yeah. So now sometimes people will go on to hospice, and doctors are notoriously poor at prognosticating sometimes, right? So So what percentage of patients do you think end up on hospice and then get out of hospice?
So I would say maybe a good 8% of the patients do graduate from service. Within the last, I want to say, a few years, it's been more patients coming on service for a very short time and they pass away, because I think there was no FaceTime with their patients, or sometimes they feel like they have to wait to the very end to refer the patients versus seeing the really benefit of hospice. Hospice can work both ways. Patients do get better and graduate from service, or they continue to decline and we're there to the very end. So it just depends where the patient's at. We have seen that. We have seen where patients, actually, I had a lung cancer patient. He decided from the very beginning he wasn't going to do treatment. 2 years on hospice care. So we just don't know. We don't know what it's going to be, right? But long as there's a decline, we continue to be there. If they get stabilized and they get better, then graduate from service. So we just don't know, but we're noticing the decline in the patient, and we want to identify that and I always tell people when we get a cold, we want our doctor to make the visit at home versus us waiting in the lobby, getting medications and all of that. But unfortunately, we don't qualify for that. We have to go to the doctor. These patients can receive all this care at home. I mean, they get a nurse visit, depending how they're doing, depending on the visits they make. They get aides that help with showers, spiritual support that sometimes illnesses are hard to deal with, volunteer support for companionship. So if their loved one needs to run an errand, they want to leave them home alone, they can get a volunteer. Social services to help with planning of funeral arrangements, insurances, resources for the home. I mean, there's just so many plans to make that they can help with. Bereavement support that's available for the family and the patient. And we're there for 13 months. So the first anniversary and another month or longer. Sometimes we have had actually spouses that become our volunteers because they saw the benefit of what we did for their spouse. Now they want to volunteer with us. So we do see that a lot. Anything related to the primary diagnosis is covered under us, meaning medications, equipment, all of that can be placed at home.
Sure. Wow.
And that's all covered through insurance. Whatever insurance is what we take.
Yeah, this pamphlet, Myths. Hospice care is expensive and will require co-payments. In fact, hospice is 100% covered by Medicare. I actually didn't know that.
Mm-hmm. Even that home one?
Oh, everything.
And everything that falls under hospice care.
It's covered 100% by Medicare. So that I actually didn't know that.
And so a lot of the times is they do wait because they feel that they are going to receive a bill and don't want to leave a bill for their loved ones. So I always tell them, insurance does cover this.
That's, I think, for a lot of people, I think that should be an eye-opener. And hospice is not about giving up, folks. Hospice is just about trying to be comfortable and to alleviate suffering a little bit. So, anything else you wanted to say?
No, and just know, families, that if you're in crisis at 2 a.m, you can call us, and as well as the weekends. And if we can't help you over the phone, we'll make a visit at that time. So that's something that will be with you. We might not be there with you in person 24/7, but we're available to you to help answer questions, make visits if we need to make another visit, but we are available to you and your family.
That's amazing. Mm-hmm. That is truly amazing. Dan, got any questions?
I mean, I'll save some for the local one on the Yuma clinical trials, but yeah, I think we touched on some things that I want to double tap on.
Okay.
Yeah.
That was healthcare literacy. Tune in next time.
Thank you.
Thank you, Carmen.